another episode of Keeping London Healthy. My name is Dr. Mario Elia. On today's episode, we will be joined by Dr. Yoni Freedhoff. Dr. Freedhoff is a bariatric expert and a professor of family medicine in Ottawa, and he'll be talking with us about bariatric surgery, which I know a lot of people have a lot of questions about, and there's a lot of misconceptions there around it. So Dr. Freedhoff will answer some questions we have about the process and kind of who should consider it and what people need to know. So we'll be joined by Dr. Freedhoff right after this message. Welcome back. So again, I'm pleased to introduce to the show today Dr. Yoni Freedhoff. So Dr. Freedhoff is an expert in bariatric medicine. He's an associate professor of family medicine in Ottawa and works in partnership with the Ottawa Hospital to manage their pre and post bariatric patients. So again, he's a great resource to bring on the show today to talk about bariatric surgery. So again, thanks for joining us today, Dr. Freedhoff.
Happy to be here. Thanks, Mario.
So a little bit of a plug. So I first learned about Dr. Freedhoff many years ago, and how this came about is I was reading a book called The Diet Fix, and I found it to be
I hear it's
honestly here, and this is not a paid advertisement. We don't do paid advertisements on this show, anyways, as far as I know. The best book on nutrition and how to advise patients on nutrition. So full plug here. This is Dr. Freedhoff's book. This is The Diet Fix. And funny enough, after that, Dr. Freedhoff and I met at some conferences here and there, and we become fairly good friends. And again, pleased to bring him on because this is such an important topic around bariatric surgery that I found patients just don't understand. The public doesn't understand. There's a lot of misconceptions around it, and it's such an important thing for people to know about that I'm again pleased as punch to be able to bring him on. So first, I guess we'll ask you. Can you tell us a bit about the work that you do in your clinic in Ottawa, and kind of what's your role in that program?
So we have a fairly broad clinic now. We opened our doors. I founded the place in 2004, and at the time we provided adult behavioral weight management with an interprofessional team. So dietitians, doctors, trainers, all working on behavior change. Now, this was 2004. There wasn't a lot else beyond behavior change. Bariatric surgery was very difficult to access. It was doable, but much more challenging to access. Medications for weight management were terrible at the time. And there really weren't much in the way of tertiary programs out there for anything other than adults. Over the years, we've sort of grown with the field. So we now are providing a Ministry of Health funded program for parents of children with obesity. It's a year-long program for parents of kids between the ages of 5 and 12 who struggle with their weight. It's delivered almost entirely to the parents rather than involving the children. I worry about getting kids that young thinking too much about weight management. And actually that program, consequent to COVID, is now offered across Ontario. So it's not just an Ottawa program anymore because virtual care has grown since COVID has begun. We also have been working for many years now with the Ottawa Hospital, where, as you mentioned, we provide basically all of the support except for the surgery for 20 to 30% of Ottawa's bariatric surgical patients. And then we also have our traditional adult weight management program. So those are the things our office is doing these days. It's nice to have been able to expand beyond just, lifestyle change because, lifestyle is something that works for a whole host of chronic medical conditions. In fact, the vast majority will respond to lifestyle, but also the vast majority, we have other options, including medications and surgeries that we have to offer. So I'm glad that obesity as a field is really maturing as far as care and support goes.
Absolutely. So bariatric surgery. So we've heard the term. How would you, what for the average patient, what is bariatric surgery? What do they need to know?
So there's different types of surgical procedures. Bariatric surgery would be surgery that is there in place to try to help people reduce their weight and as a consequence, reduce the risk of medical problems, potentially treat and put weight responsive medical conditions into remission and keep weight off longer term. So bariatric surgery, OHIP right now covers 3 different types of bariatric surgery. It is a process if you wanted to get involved in bariatric surgery, that does not require you to have surgery. So the family doctor, Mario, you refer online with a one-page form. It's not the easiest thing in the world to do, but it's easier than some things in our practices. And filling out that form would then send a patient to the bariatric registry, who would then determine which center they'd be assigned to. Center would contact them. They then start meeting with doctors, dietitians, behavioralists, etc., for two things to happen. One, for the patient to decide, yes, I'm interested in doing this. And two, for the center to decide, yes, this is a suitable patient. Now, nobody's locked into the process. So getting involved in the process, there's zero requirement of the person to have surgery. They can withdraw. And they could also then get reapplied down the road if they change their mind. As far as criteria for approval go, it would be a body mass index, which you can look online for a calculator, of 35 to 40 with weight responsive medical conditions like high blood pressure, diabetes, sleep apnea, or a BMI that was beyond 40, even if those conditions weren't present. The surgeries that get performed, there's three. There's the vertical sleeve gastrectomy, the Roux-en-Y gastric bypass, and the duodenal switch. Very briefly, the sleeve involves removing roughly 90% of a person's stomach, leaving them with a narrow banana-shaped stomach, which fills quickly, restricting what a person can have. But much more importantly, people post-surgically have a decrease in their hunger hormone levels, so they're not driven the same way with hunger. The bypass involves crafting a small pouch from the current stomach, taking that small pouch, bypassing a portion of the intestines to reconnect it. And it works the same way through restriction and a reduction in hunger hormones. And of the surgeries, it is the only one that is reversible. And then there's the duodenal switch, which starts with a sleeve. And then a year or two later, they can go back, take that sleeve and reattach it, bypassing an even larger portion of the intestines. It leads to the greatest amount of weight loss, but it definitely has the most significant nutritional risks associated with it. Some can be quite severe. And so as a consequence, it tends to get metered out only to the people with the most extreme cases and conditions. There's other surgeries that people could buy in Ontario, non-OHIP funded surgeries. These would be things like laparoscopic gastric bands, where a silicone band is put around the top of a person's stomach. The only mechanism of action of that is restriction. It doesn't change hunger hormones. The research on it would suggest it is not nearly as effective as the OHIP covered surgeries and has a significant reoperation risk, which is why OHIP doesn't pay for it. And then there's another procedure, which is a gastric balloon that gets placed into your stomach and filled up, again, works by way of restriction. There aren't any long-term data on balloons. Generally speaking, it's not something that I'd be recommending anybody for long-term use. It would be for instance, getting a person's weight down enough quickly to have a surgery, maybe, but certainly not something that should be looked at as a long-term solution for most.
And I can even speak to, obviously personal experience in my own practice, patients who've gotten a lap band without my knowledge, obviously because they can just buy it on their own. They come back and none of my patients who've had a lap band have had success with that with long-term weight loss. So
there will be some. I mean, there's success stories from every procedure and every diet. But what I will say is, from what I recall from the literature, 1 in 3 people who have a lap band will have a second surgery to either repair a problem or remove the band. Yeah. That's not a great track record. And 1 in 4 fail the surgery, where failure, the definition is poor, actually, where it's not achieving a body mass index below 30. I think it's a silly way to think about failure. Weight doesn't measure success, it measures gravity. But you're, about 4 times as likely to fail a lap band than a gastric bypass. Yeah. So again, OHIP doesn't discriminate on the basis of procedures for any reason other than efficacy and safety. And if it was proven to be safe and effective in a comparable way to the other procedures, we'd be offering it here as well.
So the procedures that are OHIP covered, again, I found with my patients that we have those discussions about getting them, starting to think about bariatric surgery. and they've spent a lot of time kind of contemplating and not wanting to kind of get that referral going. Can you talk a bit about what because I found that I almost wanted to at least get them, starting the process, because the process can be kind of a long process, and like you said, they can decide not to do it at any point. Can you talk a little bit about the process from time of referral to time of surgery, and kind of what those wait times are looking like? I know obviously it's going to be different across the province. So, roughly what you're
that's what I was going to say. It is very different across the province.
Yeah.
I know Ottawa, we are extremely good compared to some centers, where from referral to surgery, assuming no complications, no hurdles or roadblocks, probably takes between 6 and 12 months. So not that long. It used to be much longer. So things have gotten much, much better over the years. I believe there's likely still some centers in Ontario where it might take a year to 2 years from referral to surgery, but it's not the, in some provinces actually it's decades long waits. So we do more bariatric surgeries in Ontario than any other province in Canada. So as far as how it works, you'd get a phone call, you'd get sent for an orientation session. After the orientation session, you'd have the option of continuing or not. I would recommend anybody who qualifies for surgery and is even remotely contemplating it, there's zero harm in getting involved in the process because, as we've mentioned, you can withdraw from the process. But basically what you'd then be doing is meeting with dietitians who'd be working with you on the pattern of eating that will help to prevent weight regain. So as with any weight management effort, there's risk of regain, but the risk with surgery is far less than the risk without surgery. But 1 in 4 patients will regain a substantial amount of weight. But we try to reduce that risk by making sure people are comfortable with the sort of the pattern of eating before the surgery. They'll meet with possibly with either a psychologist or some sort of behavioralist, where they might be looking at the patient's mood and whether or not they're in a frame of mind that would be conducive to behavior change. Just like traditional sort of behavior change for weight management, this surgery requires planning, organizing, and concentrating post-operatively around food, around supplements, around appointments. And so if a person has a mood disturbance that is affecting their ability to plan, organize, and concentrate, it would not be wise to start the surgical process because you need those things post-surgically. Instead, you'd work on mood first and then potentially proceed on to surgery. As well, if a person had an eating disorder that was not being attended to or managed, that would not be a good candidate for surgery as well. They'd meet with doctors who would do a bunch of tests. There are certain conditions that would require treatment pre-surgically. If a person has enough of a risk factor for having sleep apnea, they would need to get tested and treated if they had it. Having sleep apnea and having surgery doubles a person's risk of heart attack or stroke in the recovery period. So the surgeons insist that it either be proven that a person doesn't have it or that it's being treated. Sometimes there's new medical conditions that crop up that we need to treat. We're not going to operate on people whose blood sugars are wildly out of control because that may affect wound healing, etc. But really, it's just about getting teed up, medically, dietetically, behaviorally, making sure that you're right, you're ready, you understand what you need to do post-operatively, and that you're a safe person to operate on. And then you'd have the surgery. Most centers will require a few weeks of an all-liquid diet pre-surgically to shrink the liver, so there's more room for surgical instruments. Then people have the surgery, and then they'll work with that same bariatric team for between 1 and 5 years afterwards. Used to be 5 years for everybody, and then the Ontario Bariatric Network, who oversees this whole thing, recommended reducing it to 1 year. We still see 5 in our office, but different offices sort of have done different things in that regard.
Okay, great. I'm just going to take a quick break, and right after this, we'll be back with Dr. Freedhoff. Welcome back. Joined today with by Dr. Freedhoff, talking about bariatric surgery. So we talked a bit about the surgical options and what to expect leading up to surgery. What should patients expect post-operatively? What's the experience they should expect?
Sure. So one of the main concerns from people are that they will not be able to eat normally anymore. They won't enjoy food anymore, and that will be very challenging for them. while it's true that the quantities that people can consume postoperatively are much smaller for various reasons, people will still be able, for the most part, to enjoy the same foods that they enjoyed beforehand in much smaller quantities. They can still go out, they can still see their friends. Challenges can be significant at times. There is a condition called dumping syndrome, which can occur with the gastric bypass, where basically food, carbohydrates, simple sugars, they dump into the intestines very quickly. That can cause fairly rapid shift of fluid into the intestines and cause them to distend, which can be very uncomfortable. Sort of same sensations as a person might experience with crampy diarrhea. Or it can affect insulin secretion and people can have low blood sugars. It's manageable through dietary change in the vast majority of cases, but it is a possibility for sure with the bypass. The other big concern with the bypass is alcohol. So the risk of struggling to control it postoperatively rises significantly. You know, I've certainly seen people who never struggled with the control of alcohol pre-surgically end up requiring rehabilitation services postoperatively. Now, you know, I don't think it's realistic to expect that people will abstain for the rest of their lives, but it really is important for people to consider this in the context of whether surgery is for them, because, you know, daily drinking, I had a crappy day drinking, these are red flags to begin with. They're much bigger red flags post-bariatric surgery because of the way the body absorbs the alcohol post-surgically. Another consideration for people, tobacco, nicotine can cause ulcers in the remnant stomach in the gastric bypass patients. So it's a no-go for sure. Smokers can't get this surgery, not because smoking's bad and we don't want to operate on you because you're smokers, but rather smoking is bad for this surgery specifically. And the other piece with regard to the bypass is if you're on anti-inflammatories and you can't come off anti-inflammatories, they are dangerous as well with the bypass. You could still have the sleeve, but not the bypass. The other thing that's worth knowing about these surgeries is that they are extremely effective treatments for type 2 diabetes, leading much more likely to lead to remission of diabetes, long-term remission, than any medication or lifestyle changes that a person could make. And so certainly if there are patients with type 2 diabetes who have body mass indices beyond 35, who are on multiple medications or even on insulin, this surgery or these surgeries would be something worth discussing for sure with your physician about whether this would be something worth pursuing because of the really tremendous impact it has on these conditions. You know, they really are remarkable surgeries. So these surgeries have long track records now, especially the gastric bypass. We've got like 30 years of data on it that prove the surgery decreases medical problems, medical risk, including the risk of common cancers, heart disease, and diabetes, increases lifespan, people live longer, and increases quality of life. Really, I think that if there was a debate about the surgery that has the greatest impact, that's not about removing a cancer or something like that on a patient, bariatric surgeries would be way up on that list. And just for people who are watching, I'm not a surgeon. So this is not me pumping my own tires. It really is a remarkable procedure.
And you've seen so many patients experience this. And even in my practice, patients who've gone through bariatric surgery, so many of them again have seen such improvement in so many aspects of their life. And there's been a bit of a paradigm shift I've found in kind of the conversations and that we're having with patients, that it's not even about weight. And I know patients think that, I want this because of my weight, and obviously they're going to see fairly substantial weight reduction with it, but it's the effect on, like you said, lifespan, the fact their mortality decreases, and there's great calculators, you can put it in their numbers and show them, here's your risk of dying before bariatric surgery, your risk of dying after, and there's such
the quality of life improvement. I mean, truly, there's not a day almost that goes by in my practice where I don't hear somebody telling me that they have their life back, that they're able to do all the things they wanted to do. I think people forget that obesity is not a choice. People do not choose to have this. So an example from my own life, I have a cardiac arrhythmia. I now need medication for it. I tried surgery, didn't work. I didn't choose to have it. I tried the lifestyle changes that'll make it better, cut out alcohol, cut out caffeine. They didn't work. So I'm on meds now. I tried surgery too. This is what we do. When we have conditions that affect our qualities of life, that lifestyle alone is insufficient to change. Despite our best efforts, we pursue treatment if it's available, whether that's medications, there's good ones for weight now, or whether it's surgery. But we need to, I think, leave as a society this notion that this is a choice, and that if you haven't been able to lose the weight on your own, you yourself have not tried. That's nonsense. And thank goodness we have better treatment than ever before to try to manage weight, because of the tremendous impact it has on quality of life and medical risk for the patients who then succeed.
Absolutely, and I know weight stigma is something that obviously kind of near and dear to your heart, based on what you do. And I can tell people out there, I have patients in my practice with significantly elevated BMIs, and I consume far more calories than these individuals. And it's not, again, their bodies just hang on to calories tighter and differently than others, and it's not a choice. And again, this is a tool, not a crutch, a tool that we know can help them have a better quality of life and live longer. And for those in the diabetes cohort is the one core I'm glad you touched on, because my patients who again have struggling with obesity, who are on significant amounts of insulin, who just can't get things, no amount of insulin seems to get their sugars under control. This is literally the best, bariatric surgery is literally the best tool to get them to where they want to be in terms of diabetes control and ultimately reducing cardiovascular risk in that. So it's that that we've talked about quite a bit. Is there a group of patients you would discourage from considering bariatric surgery? Is there?
Well, so there's all of the medical contraindications. We touched on those: poorly managed mood disturbances, eating disorders, people who smoke, perhaps some people who have different gastrointestinal inflammatory bowel disease might need to be more cautious about which surgery they pick. But no, not really, in the sense that if a person is comfortable with the idea of these changes, this is not an easy solution. There's a lot of change in organization involved post-surgically. But I think considering all the options is important. So there are people, for instance, who with medications will lose surgical amounts of weight loss. That's great. In fact, I think that is, if you could choose between losing 30% of your weight through surgery or 30% of your weight through lifestyle plus meds, do the lifestyle plus meds. There's less risk. But at the end of the day, exploring your options is really what matters. Our job as physicians is to inform patients about their options, not to judge them on which ones they choose or to choose for them. We might make some suggestions what we think might work best, but that still doesn't mean that we're going to make choices. And so I really do think that, for a very large percentage of people whose weight is affecting their health or their quality of life, this is an option worth considering. Considering doesn't mean having, but certainly might mean getting into the surgical stream to learn enough about it to make a very informed decision.
Absolutely. That's fantastic. And again, for anyone considering this, I would, both Dr. Freedhoff and I would strongly encourage you, speak to your primary care physician, and you can discuss whether, strictly lifestyle or meds or bariatric surgery would be appropriate for you.
What I can say 100% truthfully is if I was unable to manage my weight through medication and lifestyle change, and it was affecting my health and quality of life or my medical risks, and I qualified for surgery, knowing what I know about surgery, having worked with as many people and the surgeons, etc., I'd have it tomorrow.
Absolutely. Awesome. Great. Well, thanks so much for joining us today, Dr. Freedhoff. That was a fantastic conversation.
Thank you, Mario.
Yeah, that was a great conversation with Dr. Freedhoff, and hopefully you guys found that useful, especially those of you who have family, friends considering bariatric surgery or yourselves. And again, I'll give a plug here. Again, I, as a family doctor, probably have not recommended a book more than this book to my patients. It's Dr. Freedhoff's book, The Diet Fix, Why Diets Fail. It's a common sense approach. And for those who've had struggles losing weight in the past, it's an absolute must read. So highly recommended. And until next month, stay healthy.